This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Doctor Speaker Series webinar. My name is John Furman. Before we introduce our speaker, I'd like to give an overview of our free program for those attending for the first time. Again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008. The same year, my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference in Cincinnati, Ohio, to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 40 groups to date. Each group is given their own free website with a link from the directory and map. In July, we will again be a sponsor at the EDF conference in Houston, and that'll be our third conference. We received feedback that conferences provide valuable information and social opportunities that many of us cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free Dr. Speakers series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcement and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected for EDSers. The store is the only funded for this program, and it usually covers our monthly web fees. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. Always consult your doctor before making any changes to your treatment.
Some upcoming events. Just wanted to point out, everybody knows that May is EDS Awareness Month, and we are compiling a list of activities to share with all of our website viewers. Please send us your activities to be included. Also, a reminder, if you're attending the EDNF conference in Houston in July, we will be a sponsor there and have a table, so please stop by and see us. And without further ado, I wanted to introduce Dr. Staci Kallish. She is a pediatric geneticist and assistant professor at the Perelman School of Medicine at the University of Pennsylvania. And our topic tonight is an introduction to cardiac issues in Ehlers Danlos. A little bit about Dr. Kallish. She completed her pediatric residency at Cooper University Hospital and her fellowship in medical genetics at the University of Pennsylvania and Children's Hospital of Philadelphia. She is currently an assistant professor at the Perelman School of Medicine at the University of Pennsylvania and the Hospital of the University of Pennsylvania in the Division of Translational Medicine and Human Genetics. Dr. Kallish is triple board certified in pediatrics by the American Board of Pediatrics and in clinical genetics and clinical biochemical genetics by the American Board of Medical Genetics. She has interest and experience in connective tissue disorders, particularly Ehlers Danlos syndrome, including diagnosis and management of affected patients. And just a reminder that after the presentation, there will be an opportunity for Q&A. You can add your questions at any time during the presentation by clicking on the Q&A icon at the top of your screen. After typing in your question, be sure to click the orange button to submit your question. So I want to welcome Dr. Kallish, and thank you for presenting tonight. You will see your slides loading on the screen, and I am turning the mic over to you now. Thank you.
Okay, great. Well, thanks everybody for joining us tonight. Looking forward to discussing this interesting topic with you guys, and I've noticed somebody commented in the chat area after they joined that they were looking forward to finding out how much they don't know about this topic, and I think that you'll all see as we go through here that there's quite a bit that's still unclear about cardiac issues within Ehlers Danlos syndrome. So, okay, as I get used to the software here. So this is the basic plan of what we're going to talk about tonight. We'll talk just a little bit about Ehlers Danlos syndromes, about the more common types, the classical, the hypermobile, and the vascular EDS, and then talk about the cardiac manifestations. First about vascular EDS, as we know much more about the cardiac manifestations within vascular EDS, and then we'll talk about what is and is not known about heart issues within classical and hypermobile EDS, and what our current best recommendations are for management. And towards the end of the talk, we'll talk a little bit about dysautonomia, just a little bit. Okay, so you guys probably know about as much of this stuff as I do, but just as a refresher for anybody who may be newer to the group, Ehlers Danlos syndrome is a mixed group of inherited connective tissue disorders. So the disorders together are characterized by joint hypermobility, skin extensibility, and tissue fragility, and we'll talk a little bit more about all of these features. They're most commonly autosomal dominant in inheritance, but there are some more rare forms that are recessive. And so what this means is that we have 2 copies of each of our genes, one from each of our parents, and that a change in one copy of these genes will cause Ehlers Danlos syndrome. The specific gene involved with each type varies from type to type, but again, most forms are inherited in this way. This means that a person who has an autosomal dominant condition like Ehlers Danlos syndrome will have a 50% risk of passing on this condition with every pregnancy. And we know that within EDS, each type of EDS will run true in a family, which means that somebody who has, for example, the classical form of EDS will have children who could have children with classical EDS, but won't have children with another form like the vascular form. Okay, so to talk a little bit about some of these features, joint hypermobility is a diagnosis that we can make based on the Beighton scale, and I'll show you some of what this looks like in a minute. The diagnosis of the hypermobile form of EDS is based almost entirely on this Beighton scale. And so a score of 5 out of 9 or more features of hypermobility indicates a generalized joint hypermobility. And so to show you what these look like, you get a point on the scale for each of the features that you have. These features include a passive dorsiflexion of the 5th finger beyond 90 degrees, so 1 point for each hand that does that. There's also passive opposition of the thumbs back to the forearm, so again, 1 point for each hand that does that. Hyperextension of the elbow beyond 10 degrees, or also hyperextension of the knees beyond 10 degrees. These are the knees over here. And 1 point for each elbow or each knee. And then the 9th point comes for forward flexion of the trunk with your knees fully extended so that you can place your hands flat on the floor. Okay. So other features of Ehlers Danlos syndrome include easy bruising and also tissue fragility. So this includes poor wound healing, friable skin, dystrophic scarring, and this is most noticeable over pressure points in the body, such as the knees and the elbows, also the forehead and the chin. You can also find chronic joint and limb pain as a common feature in Ehlers Danlos syndrome. And then there's some question of cardiac features. So again, the cardiac features within vascular EDS are very well known, but within the other types of EDS, this is a little bit less clear. So most often we think of cardiac features as including mitral valve prolapse, which is a floppiness of the mitral valve of the heart. There's also some concerns over whether or not this includes aortic root dilation, an enlargement of the aorta as it comes out of the heart to carry blood to the body. We know that aortic root dilatation happens in other connective tissue disorders and can become problematic in some disorders, such as Marfan syndrome. And so this is a concern if it's truly a feature of Ehlers Danlos syndrome. Okay, so just to talk a little bit more specifically about the specific types of EDS, the classical type of EDS is characterized by skin hyperextensibility, widened and atrophic scarring, and joint hypermobility. We can also see features such as smooth, velvety skin, additional joint complications with frequent sprains, dislocations, and subluxations, and also pes planus, which are flat arches of the feet. We could see molluscoid pseudotumors, which are soft, fleshy lesions that are associated with scars over pressure points, and also subcutaneous spheroids, which are small, hard bodies that can be palpated under the skin that are frequently mobile and most often on the forearms and the shins. And these subcutaneous nodules actually can become calcified and sometimes can be seen on X-ray. We can see easy bruising and also other complications such as hiatal hernias, postoperative skin hernias, anal prolapse can occur in children, and cervical insufficiency during pregnancy can also occur due to the tissue fragility. So classical EDS, like most forms of EDS, and as we talked about, is inherited in an autosomal dominant form. It's most often diagnosed clinically, so a physician who's experienced in this condition can make the diagnosis. We can do collagen studies from a skin biopsy and measure the electrophoretic mobility, the ability of the collagen type 5 to move through a gel to determine if this type of collagen is abnormal, and can also pursue molecular diagnosis or genetic testing of the two genes that are associated with this condition. Until recently, genetic testing has not been used very much, although the testing is now much more sensitive and more likely to find a genetic change in someone with classical EDS. But still, the utility for such testing is still a little bit unclear. Hypermobile EDS is characterized by more subtle skin hyperextensibility or smooth, velvety skin, and also generalized joint hypermobility. So because of the joint hypermobility, we can see recurrent joint dislocations and chronic pain. Again, inherited in a dominant manner and diagnosed clinically by an experienced physician. Molecular testing or mutation analysis is not yet available for hypermobile EDS, as we do not know the gene that causes the condition as of yet. And then finally, the vascular type of Ehlers Danlos syndrome, which is distinct from the other forms, so characterized by thin and translucent skin, arterial, intestinal, and uterine fragility with rupture, extensive bruising, and then a characteristic facial appearance, and we'll see a picture of this in a minute. You can also see additional features such as acrogyria, which is a premature aging appearance most commonly seen in the hands. We see hypermobility mostly of the small joints, such as the fingers and the toes, rupture of tendons and muscles, early onset of varicose veins and visible veins, especially across the chest and the abdomen, recession of the gums. Can also see pneumothorax or pneumohemothorax, which is when the lung collapses or part of the chest fills with some blood. And we can also see a family history in vascular EDS of sudden death of relatives when the diagnosis has not yet been made. So like the other types that we've talked about tonight, this is inherited in a dominant manner and is caused by structural defects, again, in a specific type of collagen, this time collagen 3. So collagen 3 defects can be seen by skin biopsy and motility studies in a gel electrophoresis, but most often we use mutation analysis with genetic testing of the gene. Genetic testing of the gene associated with vascular EDS can also be used to test additional family members to see if they're also affected. And so this is an image that we typically use to show some of the characteristic facial appearances that we can see within vascular EDS. And so you can see some of the features here include a thin delicate or pinched nose, hollowed out cheeks, prominent eyes that are sometimes thought of to be sort of a staring eyes, and this is due to a decrease in fat tissue around the eyes, and also tight or firm ears that lack earlobes that you don't see in this picture. And this picture actually is not entirely classic for vascular EDS, although it seems that within the medical literature there is a paucity of pictures that are of people who are documented to truly have vascular EDS. And so in looking for other images, there's not very many pictures that are within the medical literature of people who are proven to have this condition. Okay, so moving on, we're going to talk about the cardiac manifestations now of Ehlers Danlos syndrome and what we know about the cardiac findings in each of these conditions. So as I mentioned earlier, the cardiovascular manifestations of the vascular form of EDS are very well described, and so we're going to sort of reverse order and talk about those first. The manifestations of the classical and hypermobile EDS is much less clear. So initially reports showed some increased risk of mitral valve prolapse, aortic dilatation, and other cardiac abnormalities. More recently, there were reports that made this seem less clear. And as also I mentioned before, dysautonomia can lead to cardiac symptoms in people with these forms of Ehlers Danlos syndrome. Although you may be aware that the EDS Awareness Group had a recent talk on one of these Wednesday nights, specifically about dysautonomia and EDS. That was on April 14th. So if you're looking for more information about that, that's probably a good resource. Okay, so cardiac manifestations in vascular EDS. So as many of you know, vascular EDS is characterized by this high risk of vascular rupture of the blood vessels. So this can include rupture, aneurysm, which is sort of a ballooning, or dissection, which is a tearing, and this can happen in major and minor arteries. The rupture may be preceded by an aneurysm or an arteriovenous fistula, which is an abnormal connection between an artery and a vein, or by a dissection. The rupture can also occur completely spontaneously with no warning. These happen most commonly about half the time in the chest and the abdomen, but can also happen in the head and neck and in the extremities. So when we look at a population of people with vascular EDS, we know that about 25% of people will have a significant vascular event by 20 years of age, and 80% of people will have a significant event by 40 years of age. And actually, about almost 3/4 of adults with vascular EDS are diagnosed after they have an initial vascular event. These significant events include not just vascular events, but also GI perforation or organ rupture. There's also a significant risk of an event occurring in pregnancy, and there's estimated to be a 12% risk of arterial rupture or uterine rupture in each pregnancy. When we think about management of patients with vascular EDS because of these high risks, surveillance is now being used much more commonly, and so surveillance is done with non-invasive imaging in many patients to try to identify these risks before complications occur. So again, the hope is to identify these aneurysms, dissections, or ruptures very early in their course, and this is being used increasingly in the recent past, now that we have more advances within endovascular approaches to repair these lesions. So in the past, there wasn't much that we could do if we found these lesions. There's an increasing use of these endovascular, sort of microvascular surgical approaches that are being used now, and so may lead to more utility in this kind of surveillance. Surveillance should be done, again, in a non-invasive way, so with ultrasound, MR angiography or CT angiography, and these may or may not use contrast injected into veins, but should absolutely avoid arterial injection of contrast, injecting directly into arteries, because this increases the risk of arterial rupture. There has not been data collected yet to see if this intervention improves outcomes or disease course, but again, this is sort of a newer advance. And again, we should avoid circumstances that are known to increase risks, so not just arterial angiography, but also elective surgeries, and trauma as much as possible. In terms of prevention, there has not been much that we could do with up until recently, but in the past 5 years or so, there's been some studies that have suggested a benefit for a medication called celiprolol. So celiprolol is a cardioselective beta blocker. So a beta blocker is a group of medications, and cardioselective means it mostly affects the heart and not the other parts of the body that some beta blockers can affect. And this has some benefits, some properties to dilate the vessels, or have vasodilatory properties. So it's believed that this may have a potential benefit in decreasing the mechanical stress that's usually seen and applied to these fragile tissues in vascular EDS. And I'll talk to you about the largest study that's been published to date about this medication. So this was a study with 53 patients with vascular EDS, and they were randomized into 2 groups to either receive the medication celiprolol or to be in a control group and not be treated at all. And the plan was to follow these patients for 5 years or until either a primary or a secondary event occurred. And so what they found was that, in looking at these patients, 5 of the 25 patients who received celiprolol, or 20% of the treated patients, had a primary event within the study, but 50%, so far more of the control patients, had a primary event. And I'll show you what some of these events are in the next slide. When they looked at patients who had primary or secondary events combined, they found that almost a quarter of patients in the treated group had any event, but 60% of patients in the untreated group had an event. So I'm sorry, this looks a little bit blurry, but this shows what some of the primary and secondary events were. So the primary events in the top part of this chart included artery dissections, artery ruptures, intestinal perforations, and death. And the secondary events, which were considered less severe, included colon perforation, muscle tear, or asymptomatic carotid artery dissections. And so what they took from this data was that this equaled a 69% reduction in the risk of having a primary or secondary event with treatment. They actually ended the study earlier than the 5 years because of the significant differences that were seen. They also found that it seemed futile to consider because there was only a small number of patients in the control group who were still free of having an event. And so these graphs show their findings in a graphical way. So in the top part here, you see these curves, which are event-free survival, or what portion of patients continue through the trial over time without having had any event. So the top part in A shows shows the occurrence of primary events. And here the blue lines are patients treated with celiprolol, and the red lines are patients who were not treated. And so you can see you are significantly more likely to have an event. So at this point, at the end of where they show their data here, more than 75% of patients who were treated had not had an event, but only about 50% of untreated patients had not had a primary event. And then in the bottom part here, they look at primary and secondary events combined. So again, you can see that fewer than 50% of people who were not treated had had an event. So more than half of patients who were not treated had had a primary or secondary event. But when they look at people who were treated with the medication celiprolol, more than 75% of patients had not had an event. And so they felt that this was a very significant finding. Okay. And now we're going to switch gears a little bit and talk about the cardiac manifestations of hypermobile and classical EDS. And we'll talk about them together because most of the studies that have been done have included both types of EDS. And sometimes it's been difficult in the past to distinguish one type from the other, and there's definitely significant overlap. So the initial large report that looked at a group of patients with EDS rather than individual case reports actually came out from Peter Beighton in 1969. So in this study, he looked at 29 patients out of his group of 100 who were diagnosed, and they seemed mostly to have classical EDS, to see how many of them had heart problems or cardiac manifestations. And what he found was only 2 patients with heart valve abnormalities. One was described as an elderly man, they did not tell us how old, but with aortic stenosis, which is a narrowing of the aortic valve due to calcification. This is certainly a complication that's known to occur in all kinds of people with age. And then there was a woman who had insufficiency of her mitral valve who had a history of rheumatic fever. And this is a known complication of rheumatic fever. So neither of these were felt to be related to Ehlers Danlos syndrome. He looked back through the previously reported cases of EDS and found that from 300 previously reported patients, only 13 had any kind of heart problem, and the majority of these were congenital heart defects, so structural problems that occurred before birth in these patients. And so from this study, he concluded that probably the incidence of these anomalies, of cardiac anomalies, is not high in Ehlers Danlos syndrome. He also wrote that it does not seem to be any consistent pattern of cardiac abnormality among these patients, and it would probably be correct to regard structural cardiac lesions as chance or very rare concomitants of the syndrome. So that makes it sound very reassuring that there may not be any significant heart issues within classical and hypermobile EDS. But then came a later study that leaned the other direction and showed some evidence towards cardiac manifestations. And you'll see for a bit this will be the theme of one study said this and then another study said something differently. So this 1980 study looked at patients who were in the hospital who had EDS. So 7 of the patients were admitted specifically for heart issues and then were found to have EDS. 12 of the patients were admitted for issues not related to their heart, but were found to have Ehlers Danlos syndrome and then had cardiac evaluation. So in the 19 patients that they looked at in this study, 16 had classical EDS and 3 had hypermobile EDS. And so they described 2 different types of patients within this study. So they looked at heart lesions that are thought to be associated with connective tissue diseases, and these are the conditions in these red boxes. And then they looked at other congenital anomalies, or again, those heart anomalies that are seen to occur before birth. So when they looked at the cardiovascular anomalies that are thought to be associated with connective tissue disorder, they found that the mitral valve prolapse and tricuspid valve prolapse were the most common. So you can see here, and this did not project very well either, I apologize, the mitral valve prolapse. In this study, they found mitral valve prolapse in 15 of 19 patients. And when they looked back through 30 historical reports, they found mitral valve prolapse in 7 of those patients. They also found prolapse of the tricuspid valve in this study in 6 of their 19 patients. They looked down here in the lower box about dilated aortic root or other enlargement in the aortic root and found a dilated aorta in 6 of the 19 patients. And in looking back through the literature, found dilated aorta in 4 of 30 previously reported patients. They also reported on a variety of congenital heart defects, which are most of these conditions down here, and reported on congenital heart defects in 6 of their 19 patients, and in 17 of 30 previous reports. So this study makes it sound like there's a significant increase in heart issues within hypermobile and classical EDS, both of those that we typically consider to be associated with connective tissue disorders such as mitral valve prolapse and aortic dilatation, and also some increase potentially in congenital heart defects. So what happened? At this point, the criteria for the diagnosis of mitral valve prolapse changed and became a little bit more strict. So the previous study showed that mitral valve prolapse was reported in almost all of the patients who were seen, but it's not entirely clear that if we were to collect that data now, we would feel that way. So we continued to look and started to collect some evidence in the other direction, suggesting that maybe there is no increase in cardiac manifestations in Ehlers Danlos syndrome. So the next study was from 1997, and this looked at 33 patients who had EDS, and they were likely all classical EDS. The study itself did not describe what type of EDS, but all patients were reported to have skin hyperextensibility. That seemed fairly significant. They also looked at 30 patients who were age and gender matched to serve as controls and did echocardiograms on these patients. So in this study, they found that 4 patients with EDS had abnormalities on echocardiograms, and 2 controls had abnormalities. And because of the size of the sample, this is not statistically significant, which meant the difference between 2 patients and 4 people could be just due to chance. At this point in time, mitral valve prolapse was suspected to occur in somewhere between 4 and 17% of women overall, and 2 to 12% of men overall. And so these findings within the patients with Ehlers Danlos syndrome was felt to be completely within what is expected for the general population. In addition, some of these patients had been previously reported to have mitral valve prolapse in the past, either because of prior criteria for the diagnosis, and some were found, let me repeat that. Some of the patients in this study were previously reported to have had mitral valve prolapse, either diagnosed by prior echocardiogram before the change in the criteria, and some were diagnosed just by cardiac heart sounds alone. And some of these patients, 5 of them, who were previously identified as having mitral valve prolapse, were found in this study to have normal echocardiograms. So that lended further evidence to the suggestion that the mitral valve prolapse was overdiagnosed in the past. In this study in 1997, there were no patients in this study who were seen with aortic dilatation or any abnormal aortic dimensions in any of the 4 places that they looked at. So they found here really no significant difference in the aortic dimensions at any of these 4 locations between the patients here or the controls. And they also found that all of the measurements of patients with EDS fell within their normal range for aortic dimensions. Interestingly, this study did find, though, that cardiac symptoms were more frequent in patients with Ehlers Danlos syndrome. So they found that almost half of patients with EDS in this study, and again, this study looked at 33 patients, had some form of atypical chest pain, but found this in only 1 of the 30 control patients. They also found that more than a third of patients reported palpitations, and that only 1 of the control patients reported this. Although they were not able to explain why these cardiac symptoms were more common in patients with Ehlers Danlos syndrome. More recently, there have been 2 larger studies that looked at cardiac manifestations within hypermobile and classical EDS that were done by Dr. Frank Romano's group at Johns Hopkins, which is a rather large center known very well for their connective tissue clinics. So in the first of these studies, they looked at echocardiograms in 71 patients with EDS. You can see here 42 of them had classical EDS and 29 with hypermobile EDS. And here they found that 20 of the 71 had at least 1 aortic measurement that was significantly above the mean, so more than 2 standard deviations above what is mean. And they found that this was more common in the patients with classical EDS, about a third of those patients, versus 17% with hypermobile EDS. They also found that the aortic root dilatation, though, was present in young patients with EDS and less so in adult patients, and suggested that this may be because the aorta is more distensible and in the young patients and may stiffen with age, or that smaller measurement errors may have a bigger impact in younger children. So when you think about what is considered normal size for an aorta, this varies based on the age or the size of the patient. And so if your normal size is smaller, then a small measurement error would seem significantly more outside of normal in a smaller patient than a larger patient. They then went on and did a follow-up study and looked at another 38 patients with Ehlers Danlos syndrome. So in this study, 19 patients clearly had hypermobile EDS, and 16 patients had classical EDS. So if you do some quick math, you'll see that this is only 35 of their 38 patients. And in this study, they actually had 3 patients where they could not classify their EDS type because these 3 were siblings who had parents who were each affected with EDS. So one parent had classical EDS and one parent had hypermobile EDS, and so they couldn't be certain if the children had one type or the other type or, had combinations of the 2. In this study also, they looked at 10 children, so 10 patients who were under 18 years of age. They found in this study dilation of the aorta in 5 of their 38 patients, or 13%, but only 1 patient had mitral valve prolapse. And when they looked further, they found that 4 patients had mitral regurgitation, which included the one with mitral valve prolapse, and 3 had tricuspid regurgitation, or backflow of blood across the mitral or the tricuspid valve. They also found some other findings that they didn't expect. So 2 patients had a suggestion of mild pulmonary hypertension, to the blood pressure higher than expected in the pulmonary vessels, which has not been previously reported in EDS, but none of these patients had symptoms of pulmonary hypertension. They also found 5 patients who were all over the age of 45 who had some impaired left ventricular relaxation. So this means this is a sign of dysfunction or of the heart muscle of the left ventricle. The left ventricle is the part of the heart that does the hardest pumping work, pumping the blood out of the heart through the whole body. This is most often thought to be due to high blood pressure in the general population. And so they felt that it was unclear what was causing this. These patients were not known to have high blood pressure, but thought it was possible that this could be due to intermittent high blood pressure that's difficult to detect sometimes in patients with EDS because of the autonomic dysfunction. And they found a few other unexpected findings that has unclear significance. They found that about a quarter of the patients seemed to have an elongated shape to the heart. They note that there's no specific established criteria for the length of the heart in any patients, but from experienced cardiologists, in about a quarter of the patients, the heart seemed to look a little bit longer than expected. They also found that they could see the right coronary artery, which is one of the arteries that brings blood flow to the heart muscle, in almost all of the patients, and that this is usually difficult to see on echocardiogram in adults. But there was no evidence to suggest that this was a problemsome finding, just something unusual that they saw. And then finally, there was one last study, which is the most recent of all of them. So this was about 3 years ago, published, 2011. And this is also the largest of all of the studies. It looked at 252 patients total. And this was a retrospective study. So they looked at echocardiograms and other cardiac imaging of patients over a longer period of time. And because of this, some of the patients had multiple imaging studies, and they were able to follow some patients over time. So in this study, they found mitral valve prolapse in about 6% of all the patients. And they found mitral valve regurgitation, or that backflow of blood, in about 5% of patients. But all of these, except for one, was in the mild range. At this time, mitral valve prolapse is now thought to be present in only about 1% of the population overall. But some of these patients had their echocardiograms before the change in the mitral valve prolapse criteria. So again, this study was going through patients' medical records to look at prior echocardiogram results. So it's possible that some of these were done and found at C mitral valve prolapse during the time of the older criteria. They also found mild tricuspid regurgitation in just one patient. So here, of all the patients they found with any abnormality, they found the mitral valve prolapse in 15 total, but they were all mild or mild to moderate. They found mitral valve regurgitation in 12, but only one in the moderate to severe range. And then this tricuspid valve prolapse in one patient, which was only mild. They also looked at aortic root dilatation in these patients and found that about 10% or 11% of their patients had a dilated aorta. And they found that this occurred in 6% of the patients with classical EDS and 12% of the patients with hypermobile EDS. However, none of these patients had more than trivial aortic regurgitation, so the aortic valve was functioning completely normally, and they found no clinical impact of this aortic root dilatation in any of the patients. When they looked at patients who had more than one echocardiogram, they found 27 people who had repeat echocardiograms, so they could look longitudinally at this aortic root dilatation. They found that 7 people had dilatation before the age of 14, and of these 7, only 1 had continued dilation into adulthood. So in the others, the dilation improved which sort of means as the children grew bigger in size, their aortas did not grow proportionally, and so their aortas became normal in size. This one person was treated with medication, but the others had only mild dilation, as I said, resolved with time. None of these patients had any symptoms. They also found, which was very significant, that no patient who had a normal aortic root in childhood had later development of dilatation, either in late childhood or in adulthood. So this seemed to suggest that if you didn't have a dilated aorta earlier in life, then it wasn't going to develop. So from this study, they concluded that aortic dilatation was seen, as we said, in about 6% of classical EDS and 12% of hypermobile EDS. And this is lower, or at the lower end of the range suggested by all of the previous studies. So previous studies have suggested an incidence anywhere between none to almost a third of patients. They confirmed their previous finding that the aorta is more likely to be dilated in younger children, and then they sort of defined young children as under 14 years of age, than in older children or adults, and that most children who had borderline dilation had normalization of this aorta with time without requiring any medical or surgical intervention. And as with previous studies, they suggested that the aorta may stiffen with age and that this wouldn't be unexpected, similar to a stiffening of joints that we can often see in people with connective tissue disorders with age. Again, they found mitral valve prolapse in as many as 6% of people with Ehlers Danlos syndrome, but felt that this may be, and this may be higher than the 1% that's seen in the overall population, but that some of these patients may have been overdiagnosed if their echocardiograms were performed prior to the change in criteria. Only one of these patients with mitral valve prolapse had anything more than a mild valve anomaly. And so from this study, they suggested that echocardiogram screening may be unnecessary in Ehlers Danlos syndrome in people who do not have symptoms or a family history of valve disease. And at the very end, we'll talk about some recommendations and what I think probably our current best recommendations are for patients. And then finally, just a little bit about dysautonomia. So, and again, if you're interested in this topic, there was a recent EDS awareness webinar from a Dr. Wilson on April 18th of this year. So it's been thought for some time that autonomic dysfunction may be a feature of Ehlers Danlos syndrome. So the autonomic nervous system refers to a specific part of the nervous system that controls many of our body functions, like our heart rate and our blood pressure, function of our pupils, and many of our other body functions. There's been frequent reports of non-musculoskeletal complaints in patients with Ehlers Danlos syndrome, and these include symptoms like palpitations, syncope or fainting, orthostatic hypotension, which is the blood pressure that drops on standing, GI system complaints such as diarrhea or constipation, and also difficulties with temperature regulation. And so because of this, dysautonomia has been suspected in hypermobile and classical EDS from a clinical basis, but hasn't been very much studied. Just over 10 years ago, there was a study that looked at dysautonomia in joint hypermobility syndrome, so the condition that has significant overlap with hypermobile EDS, with significant joint hypermobility, but likely fewer skin findings. And this study found some objective evidence of autonomic dysfunction within joint hypermobility syndrome. So just earlier this year, there was a study published looking specifically at dysautonomia within hypermobile EDS. This study looked at 39 patients, and it is notable that in this study, all of the patients were female, but this is not all that surprising because there isn't certainly a preponderance of women who have been diagnosed with hypermobile EDS, and the reasons for this may be very many, but are likely related to the fact that women seek health care far more often than men. In this study, they found that the resting heart rate was higher in hypermobile EDS patients versus their control patients. They also found other signs of autonomic dysfunction, such as abnormal sweating and abnormal responses to a Valsalva maneuver, which is an increase in pressure within the chest and the abdomen, such as that can occur with coughing or bearing down for a bowel movement, things like that. They did tilt testing on these patients who had hypermobile EDS and on control patients, and showed that people with hypermobile EDS had smaller increases in their blood pressure with initial tilting. So your blood pressure should increase to help blood flow to the brain against gravity, and they found that this process happens slower in people with hypermobile EDS. They also found that almost 3/4 of patients with hypermobile EDS had orthostatic intolerance, and that this happens earlier than in the control patients. So people who were not able to tolerate this orthostatic or standing up quickly or standing for prolonged periods of time. They found more patients with EDS were needed to prematurely end the tilt test due to symptoms when compared to the control patients. But also interestingly, as was seen in some of the earlier studies, 3 of the patients ended the tilt test due to symptoms, even though measurement showed that their blood pressure was adequate. So it's unclear what is occurring in some of these patients who have symptoms of low blood pressure, even when their blood pressure is measured as normal. They also found postural orthostatic hypotension, or POTS syndrome, in about 40% of patients, and found a more gradual orthostatic hypotension in 1/4 of patients. And so from these findings, they suggested that there's reduced sympathetic nervous system reactivity with resting overactivity. So this was evidence of autonomic dysfunction, suggesting that part of the autonomic nervous system, the sympathetic system, is overactive at rest and then has decreased reaction when it's called into play to regulate body systems. So why do we think, why would it be that dysautonomia happens in hypermobile EDS? And they found in this study that patients who had higher Beighton scores or more significant joint hypermobility, that this was also associated with lower blood pressure. So they suggested a number of possible mechanisms for this dysautonomia. One suggestion was that there could be peripheral neuropathy or something different about the peripheral nerves themselves, but it's unclear what this difference might be at this point. They also suggested an increased distensibility of the blood vessels, so that the blood vessels themselves were more stretchy, which led to increased pooling of blood in the veins during upright posture. They thought that some of the medications that people frequently use to treat symptoms of EDS may contribute. So we know that opiate pain medications can also cause dilation of the blood vessels and may exacerbate this. Some blood pressure medications and also trazodone can inhibit the sympathetic nervous system. And then certain tricyclic antidepressants, which can also be used for pain management, can block the sympathetic nervous system receptors. Other possible suggestions were that depression and deconditioning both may play a part in some patients, or that chronic pain may lead to a pain-induced overactivity of the sympathetic nervous system. So our sympathetic nervous system is the part of our bodies that sort of kicks in when we have some sort of stress to help us respond to that. So the suggestion is that patients who have chronic pain due to EDS may have a chronic arousal of the sympathetic nervous system. So to finish up just with a summary of what we've talked about so far, we know clearly that vascular EDS has high risks of cardiac complications and that these include arterial dissection, aneurysm, and rupture, and that newer diagnostic modalities and new treatments may alter the course of the disease. The manifestations in classical and hypermobile EDS still remain less clear. There may be a small increase in risk of mitral valve prolapse, and may also be a small increase in risk in aortic dilatation, especially in young children. But these do not seem to cause significant complications in most patients. Dysautonomia seems to be a part of hypermobile EDS, as was shown by the study we looked at most recently, and is likely also a part of classical EDS. So what recommendations can we make at this time? In vascular EDS, the recommendations that we can make include surveillance with non-invasive imaging, as we talked about, and potentially treatment to decrease the risk of significant events with medications such as celiprolol, and there are studies that are still ongoing in this. In hypermobile and classical EDS, we can discuss recommendations for periodic echocardiogram. So it's at this time still unclear if it's necessary that patients with hypermobile and classical EDS have periodic echocardiograms, especially in adults or older children who have had prior normal echocardiograms. The evidence that we looked at showed that the risk of aortic dilation is low if there's no dilatation in childhood, and also shows that there's very little risk of significant complications from either mitral valve abnormalities or mild aortic dilatation. But still, echocardiogram is easy and non-invasive, and so most clinicians still recommend a baseline echocardiogram. And most will recommend repeat every 3 to 5 years, even if the study is normal. And I think that the jury is still out on really if this is necessary, and for now, while we're continuing to study this, we're following a better safe than sorry approach. And certainly management of dysautonomia symptoms is helpful in patients who have these symptoms. And then I think the most clear recommendation is that there's a definite need for ongoing studies in all types of EDS. And so that's all that I have for you guys tonight.
Well, thank you, Dr. Kallish. I think we're ready for the Q&A section, and we really appreciate all that very detailed analysis of some of the research that has been done in the past. So that gets us all up to date as to where we are with that. So feel free to click on Q&A, and you can read the question and then provide an answer. Great. Thank you.
Okay. So let me see what we have questions here about. So some of these, it looks like we've talked about them already, so I'm just going to address the questions that we have not addressed yet. There's a question here asking if EDS can cause the heart to have abnormal rhythms like atrial fibrillation, or if there's another underlying condition that makes this more common. So to the best of our knowledge at this point, there is not an increased risk of arrhythmia or abnormal heart rhythm in people with Ehlers Danlos syndrome. And in the most recent review that I did in preparing for this, I did not come across any suggestion of this. Okay, let's see. So there's a question about the risk of abdominal aortic aneurysms in EDS from somebody who has classical EDS and has a family history of a ruptured abdominal aortic aneurysm. And so I would agree with the other providers who have suggested that the aortic aneurysms that we do see in EDS are typically, and we don't typically see really aneurysms in EDS, but the data so far has shown us that we see this dilatation of the aortic root. And so the aortic root is the very first part of the aorta where it comes off of the heart. We do know that when the aortic root gets to be large enough to a certain size, it's at risk of rupturing at that point. But again, we don't see the aorta becoming that large almost ever in patients with EDS. And so an abdominal aortic aneurysm is not something that we think of as being associated. That said, people who have abnormal connective tissue have abnormal connective tissue everywhere, and there's a number of causes of aneurysms, and so it's really difficult to say in one particular family specifically how much role any one factor played. Okay, and then there's another question here about someone with slight mitral valve regurgitation and whether or not this could be related to Ehlers Danlos syndrome. It's sometimes really very difficult to say in an individual patient. So mild or slight mitral valve regurgitation is not all that uncommon in the population. So, the jury's really still out on if having Ehlers Danlos syndrome increases your risk of this at all. But what we do know is that it doesn't change the management at all. So whether your EDS played some role in you developing mild mitral valve regurgitation or it didn't, the management is the same, and so that's probably the best take-home message from that. There's a question about if Ehlers Danlos syndrome is more common in people of certain ethnic backgrounds, and to our knowledge, we don't have any data to suggest that. But again, because of the clinical diagnosis, many of these, I'm sure you guys are aware, Ehlers Danlos syndrome is often undiagnosed, but we don't have any suggestion that there's any one group of people who are more likely to have EDS. There's a question about the diagnosis of POTS, or postural orthostatic hypotension, or orthostatic intolerance in people with EDS, and making this diagnosis, and whether the criteria based on tilt table testing should be different for people who have EDS. So I'm certainly not an expert in dysautonomia, but there hasn't been any suggestion that there should be a difference in those numbers. Certainly, even in people who don't fit as having full POTS syndrome, we know that from some of these studies that a very large number of people with hypermobile EDS do have symptoms of orthostatic intolerance or symptoms of orthostatic hypotension. And so I think that the best recommendation is really that anybody who has those symptoms of sort of lightheadedness or dizziness or seeing stars on standing up should treat them in the same way that we suggest people treat them, by staying well hydrated, having good nutrition, and really being most aware of this, and so getting up slowly and being aware that it can happen. There's a question about if atrial septal defect, which is a hole between the two atria of the heart, if this is more common in EDS. So some of the earlier studies that we talked about tonight had some suggestion that congenital heart defects or birth defects of the heart, which include ASDs, may be more common in EDS, but most of the more recent data does not show that there's any increased risk in congenital heart defects. We know that congenital heart defects can occur in up to 3% of the population, so they're really not nearly as rare as we might have expected. There's a question in here about suggestions for school modifications for children who have EDS and dysautonomia symptoms. There's actually an EDS educator's guide that has a number of good suggestions for children, including has information for educators, which is also useful for parents, and also has information about suggestions for modifications. We certainly, for children who have dysautonomia symptoms or may be prone to dizziness with dehydration, we would certainly suggest a modification allowing those children to have access to water. So certain schools, children are supposed to only have food or drink at recess time or at snack time or lunch. And so children who are very sensitive to dehydration should be allowed more access to water. The other modifications really just depend on the individual child. Okay, there's a couple more questions. There's one about vitamin deficiency or mineral deficiency, and if these are more common in EDS. We don't have any evidence to suggest this. And then there's one last question about patients who have abdominal bloating and what could cause this in any treatment regimens. So certainly we can see in dysautonomia, and the studies have looked mostly at cardiovascular symptoms, but we know that the autonomic nervous system also plays a role in digestion and the passage of food through the GI tract, and so people with autonomic nervous system symptoms can have diarrhea or constipation or a combination of the two, and certainly can be prone to bloating with those abnormalities. There's no specific treatments for these for patients with EDS, but the patients we treat the constipation and diarrhea the same way we would in other people. Any other questions? I do see that there's a chat asking about the Educator's Guide. I do believe that it's available through the EDNF. If not, I certainly have a copy of it electronically and can send it to the group.
Yeah, that would be great. I could actually put a link to that particular guide on our site along with your presentation so that people could easily find it. So that might be a helpful thing.
We'll make a comment and we'll do a note to myself, and we'll do that first thing in the morning.
Great. That sounds good. So any final questions? I think we're probably wrapped up. So any final comments, Dr. Kallish?
Just that, as we talked about, this is really still an emerging story, especially with the hypermobile and the classical EDS. And so, these recommendations certainly may change over time. And, we'll continue to keep you guys updated with what happens.
Fabulous. Great. Well, we really appreciate your time putting this program together, and it's been very educational for all of us. We've learned some new things.
Thank you, Dr. Kallish. Learning about all those studies, I personally wasn't aware of a lot of those, and I'm sure that a lot of those are of great help, for both our EDSers and their local doctors, as they're looking to try to connect the dots with the cardiac issues.
Fabulous.
You're welcome.
Great. Thank you very much. I wanted to remind people about our sessions. We will have another session on May 21st. You'll get an announcement through EDS Awareness site, or if you're on the mailing list, you will also get the announcement. If you want to be on the mailing list, then request the free report at our EDS Awareness site, and you'll get notified about the sessions that are coming up. We are about EDS awareness activities. This is the month of May, so those of you that are currently working on EDS awareness activities, we'd certainly like to hear about those, and that would be something that we'll post on our site. So.
And John, if we have another few minutes, it looks like there's a few questions that have popped up on the left side. So there's some questions about diagnosing dysautonomia. And so this is done mostly by cardiologists and electrophysiologists. So there's a type of cardiologist who do the tilt testing. Sometimes neurologists can make the diagnosis as well. There's a question about treatments for excessive sweating. So it's not really my area of expertise. There are certainly people who do treatments depending on if the sweating's in localized areas, but for generalized sweating, it's a pretty difficult thing to treat. And then there's a question about when heart testing stops in a young child with hypermobile EDS. I'm not sure exactly if that's what we talked about earlier, but for right now, we generally recommend echocardiogram every 3 to 5 years in children and in adults. And so when can we be sure that there's no issue with the heart? So again, the studies that we have suggest that if there's no dilation of the aorta by the teen years, and in the study that we looked at, they classified young children as under 14, then no one that they looked at went on to develop dilation of the aorta, so after about 14. But again, these are only small studies, and whenever we deal with rare disease, the study numbers tend to be on the smaller side. And so I don't know that any of us are ready yet to say there's no need to do the testing after then. I think the data certainly looks, very reassuring that if the aorta is not dilated by the teenage years, then it's not likely to become dilated, and that even in patients who have mild dilation, that is unlikely to cause any significant problems. So it's unlikely to dilate to the point where we worry about it needing surgical repair or rupture. But at this point, the recommendations, again, are still that better safe or sorry. Better safe than sorry, and echocardiogram is a non-invasive test, and so until we have data on larger numbers, we'd probably continue to recommend echocardiogram.
Okay, any other questions? Okay, fabulous. Well, once again, I appreciate all of you that have joined our call tonight. Appreciate Dr. Kallish putting together this presentation. It's been very informative, and we'll look forward to seeing you in our next session on May 21st. So everyone, have a good evening and be safe. Good night.
Thank you.
Good night.
Good night.